Hello, my name is Dr. Roger Blumenthal, and I'm editor-in-chief of the new dyslipidemia clinical community, which will be available on CardioSource in December. It gives me a great pleasure to talk to my longtime friend and colleague and mentor, Dr. Neil Stone. Neil is the Robert Bonneau Professor of Medicine at Northwestern School of Medicine. And today we'll take a deep dive into the recently released ACC/AHA guidelines on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults. Welcome, Neil.
Thanks, Roger. Pleasure to be with you.
Neil, I'm so happy for you. For the last probably close to 6 years, these guidelines have probably dominated your professional life, and you and your panel have done a superb job with this document. I wanted to just first get your views on secondary prevention and what your thoughts are for the practicing internists and cardiologists. What should they focus in on in secondary prevention in the treatment of lipid disorders?
Yeah, thanks, Roger. Our detailed evidence review tried to establish with the strongest possible evidence what really would be the best strategy to support. And then for those who have not just coronary heart disease, but we call now atherosclerotic cardiovascular disease, so that's going to include stroke or TIA of atherosclerotic origin and peripheral arterial disease, those people at the highest risk for recurrent events in atherosclerotic cardiovascular disease and atherosclerotic death, we had to focus on the intensity of therapy. It turns out for those under age 75, high-intensity statin therapy should be initiated. The evidence clearly supports that this gives a better effect if it can be tolerated. On the other hand, for those over 75 or for those who can't tolerate high-intensity statin therapy, then a moderate-intensity statin therapy is obviously indicated. And there have been a number of strategies that people have looked at in clinical practice, but we've tried to glean insights from the clinical trials because in many cases, clinicians can make that degree of intensive therapy work. So when we said the highest intensity of statin therapy, so-called high-intensity statin therapy, we're really talking about those statins that lower LDL cholesterol about 50% or more. So that's atorvastatin 40 or 80 and rosuvastatin 20 or 40. The other statins that are generally used in practice, and we have a table in our guidelines, give reductions in the 30 to 50% range. And as a general rule, a moderate intensity statin lowers LDL at least about 30%.
That's a great summary of the secondary prevention. One of the things that clinicians will notice, Neil, is that the committee decided not to have LDL targets or non-HDL targets. Perhaps you might comment on some of the thought processes behind that.
Yeah, this is going to be widely discussed. We asked two critical questions to look at this in great detail because it had been suggested that perhaps fixed targets were not beneficial. And so we wanted to take a look at that in as great a detail as possible. First, there were those who felt if you had a fixed target, it would be easier for clinicians to get their patients to goal. And indeed, that's what's happened in the past number of years. But we saw, for example, in the case of secondary prevention, where one might have reached a goal, say an LDL less than 100, but be on a moderate intensity statin, where if that person could tolerate a higher intensity statin, the evidence was stronger that they would benefit from the randomized trials. Also, some people set more stringent goals, and they therefore started adding other medications, sometimes cutting back on the statin to use the other medications, but yet the evidence, and I want to go back again, what does the evidence support? It supports using in secondary prevention intensive or high level of statin therapy if it can be tolerated. And so, if you will, our guidelines tried to focus not on a goal, but on what works best for reducing atherosclerotic cardiovascular risk in 4 groups of individuals. The first one was secondary prevention. The second one were for those LDLs 190 or more. The third, those with diabetes. And the last, a primary prevention group who had we'll talk about in a minute, atherosclerotic cardiovascular risk above 7.5%. If I could, I want to just address two arguments that are sometimes mentioned when people say, you should have stayed with goals. We looked really hard at this, and we spent a lot of time trying to wonder maybe we should. But we couldn't find evidence for one specific goal at all. Should it be 100? Should it be 90? Should it be 70? We couldn't find the evidence. We couldn't determine the magnitude of benefit if you achieve 100 versus 90 versus 85. And lastly, we were very worried about multi-drug therapy that might accrue getting to a goal when all the evidence points to using an intensive degree of statin therapy and excellent lifestyle change. For example, a patient recently I saw who had a previous MI and angioplasty, was now 3 months out. He had an LDL of 78. He was on 80 milligrams of atorvastatin. He had superb lifestyle. Some people would have said that unless he was under 70, he wasn't at goal. Well, there was no basis for that. So instead of making him feel like he had failed, we said, you're doing a great job. Keep working on lifestyle change. Keep maintaining excellent adherence to your statin therapy. And of course, if there's any problems, let us know. So we think once physicians get used to the idea of defining what works best for my patient versus just a fixed target, they will soon see the benefit. Because remember, most of the studies, the great majority, were not done based on trying to get to a goal, but indeed really were tests of fixed doses.
Neil, that's great. In the last 3 minutes, I just wanted to focus in on your thoughts on primary prevention. As you know, there was a recent article in the BMJ that said that perhaps if risk is less than 10% over the next 10 years, there's not a significant mortality benefit, we probably shouldn't be advocating statin therapy. And your guidelines have taken the tack that a 7.5% risk of a heart attack and stroke over the next 10 years may be a very good threshold to strongly consider statin therapy. Maybe you could address the mortality argument and why you decided to pick the 7.5% threshold.
Yeah, well, we took a look at the largest purely primary prevention trials. One of the problems was some of the trials had a mix of secondary and primary prevention. And when we looked solely at the primary prevention trials, we were able to determine roughly at what level of atherosclerotic cardiovascular risk statin therapy appeared to give definite benefit. And that risk was 7.5% or greater estimated atherosclerotic cardiovascular risk. And you're going to hear from, I think, from Dr. Don Lloyd-Jones about our risk calculator. But that was designed to plug in known risk factors and allow the patient and the clinician to know exactly where their patient stands in primary prevention. We did one other thing. We also wanted to make these patient-focused guidelines, and so for primary prevention. So we did say that the physician and the patient should discuss therapy before they proceed in all of the primary prevention areas. But I would point to the fact that not only does the cholesterol treatment trialist meta-analysis show benefit in total mortality, but now the most recent update of the Cochrane analysis shows benefit in total mortality and primary prevention. And remember, in their previous guideline, they didn't have enough data to say it existed. So you can see that there's an enlarging benefit. And we feel that by using the 7.5% or greater, we're addressing the large global burden of atherosclerotic risk. Now, our detailed review didn't support treating with statin therapy low-risk people. We're not saying that, but we think it's reasonable to tease out with thoughtful risk factor approaches those people who would benefit from tolerated statin therapy.
Thank you so much, Dr. Stone, for your insights. And to the audience, I want to thank you for your attention today. I hope people visit the community frequently for ongoing information about dyslipidemia. This is Dr. Roger Blumenthal for the CardioSource Clinical Community on Dyslipidemia. Thanks so much for your attention.